For those of you, for the Anglophones who tuned in by mistakenly to the French session, this is the Anglophone session for English speakers. Welcome. On our platforms, we do live stream in both English and French. So don't panic if you come into a session and you hear people speaking in French. That just means the Francophone group is sharing their experience in the Peer Hub. So just to give you a sense of what we'll be doing in today's session. So here you have we'll be live streaming on all the platforms once again. It felt like on the 23rd, last Monday, we actually ran out of time. There's so many participants, members of the Peer Hub, who are ready to share their stories. And that's where I want to turn to Charlotte. Charlotte, how are you? We're starting in, let's see how much time we have left, 9 minutes. Do you want to give us a sneak preview of what those who are tuning in on LinkedIn, YouTube, Twitter, or Facebook are in for?
Okay, Reda, and by the way, good morning, afternoon, evening to everyone, depending on where you're joining us from. So, scholars of the Peer Hub have been working on their vaccine hesitancy experiences, and many of them have had to come up with a case study, and some have already gone ahead for the Anglophones. By this morning, we had about 45 case studies that had been submitted on our platform. Yes, so I just took the liberty to go through some of them and kind of like shortlisted a few that I contacted the authors. So, and I do hope they'll be joining us to actually share their experiences with us this evening, Reda. So all that is it. But I think very interesting stories, different causes of vaccine hesitancy, different reasons coming from either routine immunization, campaigns, or introduction of new vaccines.
Yeah, exactly. We're talking about how to go from vaccine hesitancy to acceptance, of course, in the context of the COVID pandemic. We'll be starting in just under 8 minutes, so stay tuned. You stay here, don't go anywhere, and we'll be getting started in just under 8 minutes. Oh, and there is one very important event, Charlotte, I believe, that we have not yet mentioned, that should be of great interest to all these scholars in the Peer Hub, and that is Sohini. I wonder if Sohini perhaps has a singing voice. I'm certainly not going to volunteer. I would not do that to members of the Peer Hub. But while we are waiting, Sohini, would you be up to sing happy birthday to Charlotte? Something tells me that...
Absolutely. I don't know how tuneful that is going to be, Charlotte, but I'll be really happy to do that.
Wow. Thank you, Sohini.
As we know, Charlotte Mbu is a poet. We're starting the Global Assembly in under 7 minutes, but we are like a family. We've been working together since July, and for some of us have been working as scholars for 4 or even 5 years now. So Sohini, you are in India. Charlotte Mbu, who's a member of our core team, is in Cameroon. We'd love to hear a birthday song. Do you feel ready? And of course, I'm putting you on the... Yeah? Okay. All right. The floor, the microphone is yours.
Oh.
Okay. Happy birthday to you. Happy birthday to you. Happy birthday, dear Charlotte. Happy birthday to you. Yay!
Wow.
Thank you, Sohini. All right, and scholars are really going, Peer Hub members are really going all out with the applause.
Thank you very much, Sohini.
All right.
You just made my day.
You're welcome, Charlotte.
Okay, well, this applause is just keeps going. Oh, that was a bit abrupt. Thank you, members of the Peer Hub, and happy birthday to Charlotte. Of course, as a family, we celebrate these occasions. We also know some members of the Peer Hub have written in to when they fall ill or when they lose a family member. We are with you in those times as well. We also have some, to change the tune a little bit, we've got about 5 minutes, and I think we've got some... so this is not going to replace our anthem, but I hope you'll appreciate this. And see you in about 5 minutes. If you're just joining us on Facebook, LinkedIn, YouTube, Twitter, or Facebook. We're right now live streaming on all these platforms. And we'll be getting started with the formal program in just under 5 minutes. Thank you, Sohini. If you're just joining us now, in just under 4 minutes, we'll be getting started sharing stories about vaccine hesitancy and how health professionals working in countries all over the world are facing vaccine hesitancy and moving individuals and groups from hesitancy to acceptance. You'll be hearing some first-hand stories, and you can join us for the second time. We're really following up on an event that we held on the 23rd of November. We had some wonderful presentations. We ran out of time, and so this assembly of the COVID-19 Peer Hub, we're once again live streaming for the second week in a row on LinkedIn, YouTube, Twitter, and Facebook, just because we have so much to share. And we have some folks who have been working on their case studies. For the first exercise, looking at how to respond to COVID, we had more than 700 projects, action plans developed and peer-reviewed by participants of the Peer Hub. We'll see how many there are this time, but it's not only the quantity, it's also the quality. See you in just under 3 minutes. Stay with us. We'll be getting started very soon. Stay with us. We're starting in just over a minute, or under a minute and a half. See you soon. We'll be kicking off some remarkable stories you'll get to listen to from frontline practitioners working in all parts of the system on how they moved individuals and groups from vaccine hesitancy to acceptance. Warm welcome to you. This is Reda Sadki from the Geneva Learning Foundation. You're joining us for the COVID-19 Peer Hub from Hesitancy to Acceptance. We're right now live streaming on all the major platforms, so you can find us on our LinkedIn page and follow this event if that's your preferred platform, on YouTube, Twitter, as well as Facebook. With me is Charlotte Mbou, and I'm going to hand it over to her because she has prepared some remarkable stories and worked with their authors to share them with you, to share their experience and share how, when confronted with individuals or groups who were reluctant or had fears about vaccines, even though these vaccines were available, actually helped them overcome that initial reluctance, hesitancy, or fear about vaccination. Charlotte, how are you doing?
I'm doing great, Reda, and more so now with the wonderful wishes that I just received from the scholar community, the COVID-19 Peer Hub family. So I just want to thank, first and foremost, everyone for the best wishes ever since the weekend and up till now.
That's right. We are a family. We've been working together since at least July 2020. Some of us have been building the Scholar Network. We're now with getting close to 30,000 members and participants, including several thousands who are active, who have been active at one point or another in the Peer Hub, and hundreds right now who are developing their case studies. So for those of you joining us who are not members of the Peer Hub, first of all, a warm welcome. I want to make sure you feel welcome, and I want to explain a little bit. I'm going to give a rundown for the participants of the Peer Hub who are actively working on their case study. There are things that they need to know, and I want to run through those quickly before handing it over to Charlotte, who will be introducing the authors who are going to be sharing their case studies. So for members of the Peer Hub, if you're actively working on your case studies, you've got one goal this week, and that is to finish and submit your case study. That deadline is very important for at least two reasons. The first reason is that if you don't submit by this deadline, you won't be able to participate in the week 3 activities, which is focused on peer review. The second, and perhaps the most important reason, is that in this exercise, as you know, if you did exercise 1, but if this is your first one, I'm going to explain that there are going to be 3 colleagues who will be dependent on your feedback. Without you, they will not be able to make any progress in the exercise. They need your feedback. They need your input. And in the same way, you're going to need the inputs of 3 of your colleagues. If those colleagues do not honor the commitment they have made, not just to the exercise, but also to you, then you'll be left without that feedback, and you might find yourself stuck with respect to this exercise. So we're right now in week 2. We've got that deadline at the end of the week. The other thing I want to say is in weeks 3 and 4, we're going to be looking at prospective scenarios for future rollout of COVID vaccine. So we'll give you the details on exactly how that's going to happen. That's going along to be alongside the case studies. I also, and in fact, coming back to the case studies, even though the deadline is Friday, already 45 scholars have submitted their case studies. Just make sure you're submitting the correct document. And I believe, Charlotte, can you tell us why you said that?
I said that because we noticed that some people actually, instead of submitting their case study, resubmitted the rubric, and some others submitted the empty template that's not filled. So, and going through some case studies, I found that they were quite very summarized, some missing information. So I could have thought that some people may have submitted their drafts. They didn't have the time to really fine tune it or to follow the guidance, the guidelines that are spelled out in the rubric, rather.
Great. Thanks. All right. Before we go any further, there are people joining on all the major platforms. I really want to take a pause to acknowledge them and say you can ask questions, make comments. We're reading all of them and we'll be sharing them on screen. You're going to see how this works. So first of all, hello back to Emanuela Chinonye Odunze joining from Nigeria. Izuugo Promise also joining from Nigeria. Now, Amel El Tahir says, connecting from Quetta, Pakistan. Glad to be here. Happy birthday, Charlotte. And I think there's one more comment from Amel that might be about the music you're hearing in the background. Dr. Suman Arvind also says, happy birthday. Wow, Charlotte, you have a lot of fans and from all over the world, as you can see here. Dr. Tanushree Mandal from West Bengal, India, one of the most active and prolific and helpful scholars. Amel Altahar, yes, that's your third comment, Amel. Whenever you join while you're working in Pakistan, this reminds you of lovely Africa. Hadiza Hussein says, hello Rida. That's also from Facebook. I think almost all comments are coming in from Facebook, but if you're on LinkedIn or Twitter, you can do the same. Gershon Woolar, Francis Ibama, Odile Nwango, who says, greetings to all. Dr. Tanushree Mandal says she's excited to hear the case studies. And then Dr. Alumra Umar from WHO Somalia. That's it for now. The last point I want to make for members of the Peer Hub is that if you need help with a platform we're using for this, Peer Grade, remember you can join the SOS. You can send out an SOS to the accompanists who are participants just like you, full-time immunization professionals, but they have done this before and they've expressed that they're willing to help you. So that's it for the update. Remember, and that if you need more help, tomorrow and every day through Friday, once every day in the morning Geneva time, but afternoon or evening, whatever it may be for you, you can find the accompanists and ask for help and support. And on Wednesday and Friday, Charlotte, would you like to tell us why these lightning sessions are important?
Definitely, Reda, and just going through the few case studies I went through today, I'm actually more convinced that these lightning sessions are very important and are necessary. Why? Because we get to help scholars develop their vaccine hesitancy case study, because one scholar shares their experience. At times when they share, there may be some missing information, there may be some details that are missing, and Francois Gaz is there to ask them questions that will cause them to dig deep into their memory and bring out the details that will be very useful and helpful as far as vaccine hesitancy situations are concerned. And just to add, Reda, that it's most often vaccine hesitancy has to do with communication, and communication is all about words, the choice of words, the persons involved, and all of that. So with this, this lightning session, scholars will have the opportunity to know exactly what was said, who said what, when was it said, to make the difference, to cause people to move from hesitancy to acceptance. I really want to encourage scholars to join, and even if you have already submitted your case study, please do well to join, because you have the possibility of going back to revise. Thank you, Reda.
Great. Thanks, Charlotte. I see Lisa Menning from the World Health Organization has kindly joined us today. She presented last week. Thank you, Lisa, for joining us once again. Now, I've got a very special and very good news. Lisa has offered and accepted our invitation to hold a workshop this Friday with scholars to hear and listen to your case studies and give you feedback. Now, she is at WHO. She is the file holder and really the person who is working on these issues. Lisa, would you like to say a word about what your expectations are from what you heard last week, what you saw and heard last week, and what scholars are going to be doing this week, which is to actually finish their case studies? Would love to hear from you.
Sure. Thanks a lot, Rita, and hi, everyone. So I just have to say that I'm really looking forward to seeing some of the case studies and the great work that I'm sure is going to come from this cohort. The questions that were asked last week and a lot of the comments made were already excellent and very insightful. So I really do feel like you're probably on the right track, and I'm just looking forward to seeing what comes forward. Thank you very much, everyone.
Great. Thank you as well. So Charlotte, who shall be our first presenter? Can you tell us who and what we should expect?
Exactly, Reda. I've already invited Adunola Oyegoke from Nigeria to unmute herself. She's going to be talking about handling an issue of vaccine hesitancy during an immunization campaign against polio in her country. So Adunola, your mic is already unmuted. Go ahead, you have the floor.
Yeah, good afternoon, everybody. My name is Adunola from Abuja, Nigeria. So I'm going to be sharing my story about vaccine hesitancy that happened while I was deployed as a management support team to Kogi State in Ankpa LGA. So the situation occurred because the caregiver had concerns about the safety of the vaccine for our ward. and she refused to let the team vaccinate the child. So while I was supervising the team, I was informed of the case. So I accompanied the team back to the household where it happened. And the people involved were the vaccination team, the world focal person, the community leader, and the caregiver who was hesitant for a child to be given the vaccine. So, and the vaccine involved was the BOPV vaccine that was used during the campaign. So, on arrival at the household, the caregiver, according to the team, there was one eligible child in the house, and the caregiver was already aggressive, and she wanted the team not to return to her compound because she doesn't want them to give her child the vaccine, because she's of the opinion that the members of the team are protecting their own children while exposing other children to a vaccine that cannot be trusted. And I had a challenge because I did not speak the language, so there was a language barrier, so I had to engage a translator who helped to translate what I was saying to her and what she was saying. And so during the initial phase of our engagement, while I engaged the caregiver, she was not cooperative, and she was just insulting the team and telling us to go away, that I want to poison her child, that she doesn't want that. So she refused to talk, and she just kept on being insultive while I was trying to ask her what her concerns were, so that I would know what she's afraid of with her child receiving the vaccine, so that I will know what to tell her. So I was persistent, despite her being insultive and ignoring us. Even the team members, because they could speak the language, they were a bit upset, and they were telling me, oh, I think we should leave because this woman is really being insultive and they don't like how she's doing that. But I told them that no, we have to be patient and we have to just explain that the vaccines are safe to her. So I started talking to the woman through the translator. So I told her about things that the team had in place to ensure that the vaccines were safe, which included maintaining good cold chain right from the state level where the vaccines was collected up to the ward level. And I also told her about the VVM, which I showed her and explained what it meant, and that the vaccine was safe and it wasn't expired. I also showed her the expiry date. And the team had an AFP pictorial which they carried with them. So I explained to her what AFP is and what polio is, and how the vaccine would help protect a child from getting polio. So what changed that made the woman to now listen to me was when I informed her that I had 2 daughters, and I actually brought out a picture of one of my daughters on my phone that while she was receiving the same vaccine that she was afraid of getting for her child. So after she saw that picture, she relaxed and she told me, oh, so you have a child too, and you allowed your child to take the vaccine? And I said yes. So she now said, okay, if your child could take it, then that means it must be safe. So she brought out the child for vaccination, and to our surprise, initially the team were told that there was only an eligible child in the household, but she brought out 3 other children that were also eligible, which I think she was hiding them in the house before, away from the team. So she brought them out and they all got vaccinated. And after we finished the vaccination, she asked about routine immunization, and then she mentioned that she was actually very surprised that I was patient, despite the fact that she was being insultive, and that I actually stayed back, that I didn't care what she was saying to me. And I was able to give her guidance on how to ensure that our wards get the immunization, the routine immunization. So for part 2, reflecting on the story, I think it's actually okay if caregivers are concerned about vaccine safety, because as a parent myself, I know that it's very important to be sure that you're not exposing your children to anything that might be an health risk. And so it is our duty as part of the vaccination team as healthcare workers to be able to explain these things to the caregivers so that they will be able to allay their fears. And my engaging her was able to convince her to let her child take the vaccine because I was able to show her that the vaccines were safe by using my knowledge of the VVM, of the cold chain, and of the and of the and of the checking of the expiry date of vaccines. I was able to use this to convince her that the vaccines were safe, and also showing her that I'm a mother made her view me as also being in her shoes, and so she was able to agree to have her wards vaccinated. So, and I think what I would have done differently looking back now was I would have actually allowed the vaccination team to be the ones to actually engage her instead of me taking the lead and doing the engagement. Because looking back now, when they were making attempt to vaccinate the child and the woman refused and became insulted, they were upset, and so they withdrew and didn't want to go back there again and just wanted to report it as a case of non-compliance. So I think looking back, if I happen to be in such a situation again, I will actually push for them to be the one to engage the woman and use the knowledge of the training they've had on VVM, cold chain maintenance, and other vaccine safety measures to actually talk to the woman about the safety of the vaccine. And one major limitation, like I mentioned earlier, was the language barrier, because along the line, I only know that I was telling him things that I know, but I'm not sure whether the translator was able to interpret it properly to the caregiver, or maybe he missed out some point. I wasn't sure about that. So that was a major limitation. And secondly, the vaccination team, they were not so confident in their own knowledge, in their own capacity to be able to engage the caregiver.
Okay, thank you very much, Adunola. Reda, what?
Yes, Charlotte. So first of all, a number of people, more people are joining on the different platforms. We're live streaming on LinkedIn, Facebook, Twitter, and YouTube. Thank you, Adunola, for this, for sharing your case study. I have appreciation that you covered both parts of the case study, the description and then the reflection. There is a comment from Tanushree Mondal. Let me see if I can get the entire comment. No, it's here. Yes. In fact, the real life story of Adunola reflects leadership and management skills in getting away with this vaccine hesitancy instance and thereby help in mobilizing the community. Patience, perseverance paves the way. Thank you, Tanushree, for this comment. Let's turn first to Lisa Menning from the World Health Organization and then to Dr. François Gasse. Lisa, yes, I'd like to ask you to comment, perhaps advise on two distinct aspects, having listened to Adunola's story. First of all, first question, what would you say sounds like it would be really important, super important to make sure it's in Adunola's written case study? You just heard an oral summary of it. And second, what would be your advice with your expertise and your knowledge of the evidence on these complex issues in terms of your response to her approach?
Firstly, thanks so much for just sharing with us that experience in your case study. So to respond to the two questions from Reda, so what would you include in the case study? So from my experience, I do think it would just be valuable to really recount the main milestones, if I can call it that, or the main turning points on this journey. So I think in general, just summarizing the story, but making sure that the key points where you felt that there was an element of interaction that started to progress and advance the dialogue and the understanding. I think that's what would be particularly useful. And secondly, what are the any recommendations that I would have? So I would say that in general, the approach that you took sounded really good. I'm not sure whether I caught this or whether it might have taken place and you didn't mention it. But one thing that I do recommend and I do think is useful and is in a way supported by the evidence as well is actually really asking enough questions to understand why this person might have these concerns. So if they are talking about certain concerns related to vaccine safety, for example, find out why they have those particular concerns or where they're coming from, or where they might be hearing that information. So I would just, advise on asking a few more questions before you really start to explain things to make sure that your explanation is really targeted to where their underlying concerns exist. That's the only thing I'd really suggest based on what you described. Otherwise, very well done. Thank you.
Thank you.
All right, thank you, Lisa Menning from the World Health Organization. Now, Dr. François Gass, comments, reflections on Adunola's oral presentation of her case study.
Thank you, Reda, and thank you, and hello to everyone who's online today. Very interesting case study, and bravo for succeeding in getting the lady accepting to get her children immunized. Maybe to complement Lisa, what I was interesting was your reflection at the end. I suppose that in every campaign, you're facing some vaccine hesitancy for all sorts of reasons. You have digged in to try to understand and respond to that person concern and convince her. But of course, you're one person. And you started mentioning that you feel that in the future, you would like to equip all your frontline workers to address those hesitancy for reasons you have shared. So in my questioning is, he said, what would you do? What were you doing before you didn't do? And what will you do now to reduce the number of such vaccine hesitancy in the future, because polio campaign will continue. And I suppose you will have incidents of vaccine hesitancy coming on, and everyone wants to reduce the magnitude of it. And you have started, can you elaborate on exactly what you would do with your staff to prevent, to reduce the number of such vaccine hesitancy?
Yes, to prevent such situation in the future, I think with the LGA team, we'll create more awareness to the caregivers, and there will be emphasis on vaccine safety, so that it will allay their fears on whatever they may be thinking about, they may be worried about, that is making them not want to take the vaccine. And secondly, the healthcare workers, their training would improve on the training to ensure that they actually understand the reasons why they are being taught the simple things like VVM, the cold chain maintenance. Because from what I've seen during a number of campaigns that I've supported as a MST, I noticed that the health workers, they really don't, they feel they need to know the VVM and the cold chain, so that when you as a supervisor comes to ask them that, oh, do you know what VVM is? They feel that's the reason why they need to know it, not because they should have that knowledge to be able to use it when interacting with caregivers. So in the future, I think for training health workers, more attention would be paid to that. And then while creating awareness for the campaign, there would also be a focus on vaccine safety, messages on vaccine safety, so that the caregivers will know that the vaccines are safe. Thank you.
Thank you very much for clarifying that point.
Thank you to our first presenter, and to Lisa Menning from WHO and Dr. François Gass. Charlotte, back to you now, so we can listen to the next presenter, member of the COVID-19 Peer Hub, who's been working on their case study, looking at, starting with a question: can you think of a time when you helped an individual or group overcome their initial reluctance, hesitancy, or fear of vaccination, and being able to move that person or that group along? Charlotte?
Yes, Reda, my next presenter is Maria Fernanda Monzon from Argentina. Generally, when we think of vaccine hesitancy, we think of maybe caregivers, parents, community members. We hardly think about health caregivers being the ones that we are trying to get them to accept. So I'm really looking forward to hearing Maria Fernanda share her story. Maria, your mic is already unmuted, so please go ahead.
Hi, thanks, Charlotte. Good afternoon to everybody. So my case is vaccine hesitancy in a health worker during the pandemic. I am, to give you a bit of context, I am the director of a healthcare center in a small city in northern Argentina called Corrientes. It's a public institution. It depends on the Ministry of Health in the local level. It serves about a population of 7,000 people, more or less. And like my health center, there are a lot in the city, about 35. So as part of one of the things that I do every week is I go to a vaccine distribution center that is located downtown. And I stock up on the vaccines that I will need for this week. So we have, a way to ask, because we know how many kids will be coming, and we get all the vaccines needed. Like myself, all the other health centers go to this same vaccination center that distributes vaccines, but also you can get your own vaccines there. So what happened, it was about 2 or 3 months ago. I went to pick up the vaccines, and I was having a conversation with the chief nurse who is in charge of the vaccination distribution center, and she's the one who we refer to with all the numbers of how we're doing with our stock and how many kids get vaccinated. Well, she runs the whole vaccination program, let's say, for the city. So I was just, chit-chatting, making small conversation, and I asked, because I was worried about my health center having a big decrease in the parents bringing their kids to vaccinate. So I had also heard about a study that was being conducted in Buenos Aires, which is the capital of Argentina, and one of the biggest pediatric hospitals was talking about 40 or 50% of decrease in vaccinations. So in routine vaccinations. So I asked her, I'm like, so how do you see it here? Are more kids coming, or are the parents bringing kids? And her answer was, well, sadly, yes. A lot of parents still bring their kids, and I always tell them not to come because COVID-19 is a risk, and that there's going to be another opportunity, or sometime, in the future, they can get their vaccines at some other point, because nothing is going to happen. So after the initial shock, obviously, my comment for that precise moment, obviously that there's a lot of better approaches, I guess, but that was immediate. The approach that was needed was to explain without insulting or without going over her authority, maybe, that, well, I told her that I was involved in a peer hub with a lot of other countries, and that, the main thing that everybody is doing is encouraging vaccinations. That is the worldwide rule, that COVID-19 obviously is a risk, but with all the steps and all the protocols that we all follow in the city, and I'm sure all over the world, well, here there's people have their health workers have their protection equipment. There's only one companion per child and mother or parent will come with a face mask. You will keep the social distancing except for the Vaccination Act itself. And with all this, the risk is minimum, but the vaccines are much needed because of course, all the other diseases that we prevent with vaccinations. So because I was talking with a health worker that is, knows a lot about vaccination, I didn't feel the need to go into details about vaccines, but I did go pretty much into vaccination during the pandemic. So as a reflection, I think that the shocking part, or what is the difference with other hesitancy case, is, as Charlotte was saying, we don't usually think that hesitancy comes from health workers, but it does. This pandemic caught us all of us, obviously, off guard. And the fear of the COVID was bigger than the fear of, immunopreventable diseases that are still going on and that are very important to still prevent. So I think that this makes us think a lot about our trainings and how we are facing from the health workers, because we are the ones that are to convince other people to come and vaccinate too. So in this case, it was just a conversation, a very informal conversation from the door where I was waiting for my vaccines. But I think that there are other ways that we can do it, gently, always, never accusing, never being reproachful, and just, presenting facts clearly, presenting the importance of vaccinations. That's it.
Thank you, Maria. Back to you.
Thank you.
Back to you, Charlotte. Before we go, if there's anything you'd like to add or comment or specify, before we go to Lisa Menning from WHO and then Dr. François Gass.
So to me, it was when I read the case study, it was surprising to me because generally you don't expect to see something like that. I would have just wanted Maria, if she could, to say at the end of the day, what happened? What did the healthcare giver tell her that was she going to change? That is the end result, the outcome of this. And just maybe to say, in one of the sessions last week, we got from Cameroon, the lady that said, many a times where she works, healthcare workers, their own children are not immunized and they don't even accept to go out for immunization, for outreach sessions. So it's like it's a problem that is more and more recurrent among healthcare workers. So Maria?
Yes, actually, after this short conversation, she did agree with me. She said, well, yeah, if you put it like that, you're right. And she did accept. She didn't at all put any, resistance or anything. And I believe that it will change, especially because she does have contact with a lot of the other directors or people that come for the vaccines, and she can spread the news too, encourage vaccinations, let the kids come, let the parents bring them, because we are taking every safety measure that we can possibly can to make this a safety environment for kids to get vaccinated.
I'd like to share Sohini's comment. You can see it up on screen. She says, I like Maria's case study because it teaches us the importance of always keeping our eyes and ears open and have conversations. Conversations give so many hidden clues. We're now going to go to Lisa Menning and then François Gass for comments and feedback to Maria. Another message, a great message from Odile Nwangu, have a right information. It's the main part of communication. When the information is right, the communication can be fluent. So let's start with Lisa and then François.
Thanks so much for this excellent story. And I have to say, it really is, we find it surprising and sometimes difficult to respond to health work hesitancy. And I think that, there are two things to keep in mind. One is, again, similarly, asking questions to really understand what's the underlying issue and to really get to the bottom of the problem. And the second, I think, is to avoid this reflex to correct the person. And I think it's difficult when, particularly with a health worker, we find it hard to understand why they would have such beliefs or why they would be questioning vaccination. But I think if we often just kind of dismiss where they're coming from and what their concerns really are, I think we can end up, in even more of a difficult position in terms of trying to start to bring them along and change the direction of where they're going. So it again starts by listening, getting to the underlying issue, avoiding this reflex to correct and to change their views immediately, and then to bring them along in this conversation. And sometimes it also means doing some work at a community level. So this person might be working in a community where there may be a community leader or there may be some influential people who are really at the heart of these types of perspectives. So trying to address this problem actually is not situated with the health worker themselves, but with someone else in the community that they live who's influencing them. And so by asking these questions, it helps to lead us on the right track to really being able to help resolve this in the right way. And the last thing is that sometimes we need to question things ourselves. So depending on how we're managing to progress with this problem, a solution also is to think about the training and support that's been offered to these health workers, because that also might mean that it's time for a refresher, for rebuilding certain skills to also help bring them along, to help enable them to reach the right conclusions. So it really can be a multifaceted problem, and there might not be one single solution to addressing these kinds of situations. But I think you're definitely on the right track. So just a few little refinements there in what I've offered. Thank you very much.
Thank you, Lisa. Lisa Menning is the technical focal point responsible for the area of vaccination demand and behavioral sciences at the headquarters of the World Health Organization. She's accepted our invitation and has offered actually to workshop with participants on Friday. So for members of a peer hub, you'll be receiving an invitation to that if you want to present your case study and get some great feedback, advice, guidance, and just converse and engage with Lisa. That'll be happening Friday on top of this Monday session. François Gass, we would love to hear from you as well. What are your thoughts and reflections on this case study from Maria?
Thank you, Maria. I think what I really enjoy listening to you is to point out that the health worker is a critical partner and maybe one of the critical focus for communication. And very often there is a tendency in many vaccine hesitancy to put the burden on the mother. And I've seen it many times, and you put now together the health worker and the mother. And it's a team where the trust, many surveys have proved that trust in the health worker is one of the critical elements for acceptance and one of the trusted persons. So if there is a doubt, you have highlighted that some health workers have a doubt. I've seen it in my island where health workers, they close everywhere, and health workers were maybe the most frightened by COVID and far more frightened than the mother, and ask mothers not to get for the time being that the things will recover. We just need to wait some time. So I think all your conversation highlights the importance of providing the right information to the health worker that will then be equipped also to transfer the reassurance to the mother. If you doubt, the doubt will be perceived by the mother. So it's very great that you focus for once on the health worker, which is rarely mentioned in many of the vaccine hesitancy. So thank you very much for highlighting this point.
Thank you.
Thank you, François. All right, Charlotte, I think we need a round of applause for our speakers and to encourage health workers, health professionals who remain the most trusted advisor and influencer on vaccination decisions in many places. We need to support each other during the pandemic to continue providing trusted, credible information on vaccines and prepare for the day when there will be a safe and effective COVID vaccine in your country, and you're likely to be involved in its introduction and rollout. Back to you, Charlotte. What's next?
Thank you, Reda. I'm turning now to Samuel Maloge Badiekang from Ghana. So Samuel, if you're getting me, you can, okay, your mic is already unmuted. You have the floor. You just introduce yourself and go ahead with your story.
Okay. Yes, I'm Samuel Malogai. I'm speaking from Ghana. Actually, I'm a staff at the Regional Health Directorate as a research officer. Actually, this is a next step of the work that I started about 3 months ago. Previously, I was working at the district level. But this my story is based on the time that this COVID-19 started. We had high heights of the COVID-19, but after August, somewhere August, we started having the peaks dropping. So now we had it that it has reduced to.
Samuel,
Hello, can
Samuel,
you hear me?
sorry to interrupt you, but there is some background music that is kind of like disturbing your presentation.
Which
Can you
sounds
move
like
away
really
from the
nice
noise?
Ghanaian music, but maybe not
Yeah.
while you're presenting, if there's any way to. Thanks, Charlotte.
Is it now okay? Is it okay
The,
now?
a little bit better, but the music is still kind of like loud.
Okay, okay. All right. Then I will have to give a distance.
Yes, please
Yeah,
do.
so as I was just saying, this one, my story started somewhere in this November. We had a campaign on yellow fever vaccination. It's a subnational program of which two districts undertook this particular program in our region. So I was one of the supervisors to a team that was assigned to visit where the vaccinations were taking place to see how the vaccination was happening. But mostly, we do usually have something we call EOC meeting, emergency operation center meetings, where we usually meet to discuss issues that we find out from the field. It was one of the day two when we were doing the vaccination campaign. A team came and then was telling us about the incidents where they met a vaccinator who said that he was really mishandled by some galamsey operators. Yeah, when we talk about galamsey, these are uh, like illegal miners who operate within communities. So when we were informed about this, they really described the situation to be very scary, which but we usually know that in that particular group of people, it's not usually one people, mostly over 1,000 population, which who can receive the vaccination against the yellow fever virus. Creates the opportunity that this particular group of people would not be vaccinated. And we had the impression that because they didn't want team to vaccinate the people, that's why they actually tried to attack them or to attack the person. Attack them. Hello, can you hear me?
We are getting you, Samuel, but your line is breaking. So please, can you just go ahead rapidly?
So when they stopped, so we just organized, and then I discussed them with them that with my previous experiences at the district level, mostly the guarantee operators do not usually attack people. With my previous experiences, what they usually do is that when you send them with health services, especially with TB screening, they usually give us the opportunity to screen them with TB, and then those that we identified to be TB positive, mostly we do go there. We ever have some multi-drug resistance, so we usually go there periodically to provide the treatment or the management of that particular TB case. So when I shared my thing with the whole team, they were impressed and they were happy that it's possible that there's a solution that we can prevent the people from becoming susceptible to the yellow fever virus through the vaccination campaign. So I was asked to join the team so that we go there. So what we did is that we first contacted the leaders of the Galamsey operating site that we'll be coming there to have a meeting with them. Mostly they are informal group of people, but they usually have their leaders as well. So when we scheduled the meeting with them, we went and met them. And then when we met, we introduced ourselves as health staff from the regional health directorate. And then we told them about the vaccination campaign. And when we told them about it, they said that okay, fine. They are happy to receive that that news, because mostly when they look at the news, this one is something that they have already heard within the community. So if they have heard it, they are also happy that they will be receiving that service, because ideally, because they are informal group of people, they would have been sidelined and would not be vaccinated. So they were happy that we came there. But they also further explained that the attack it was not on the purpose that because the person was coming to vaccinate them. but mostly they usually see that when people wear a red dress to the community, usually it's a sense of danger to them. And because of that, if you are someone who is dangerous and then you are bringing service to them, there's a possibility that maybe you are coming to harm them or something of that sort. So they see that maybe it's a source of danger. So that's why they try to attack the person. But when the person introduced himself as a health worker, they actually did not go ahead to do whatever they wanted to do to the person. So they agreed for the team to be vaccinated. And we really vaccinated, from that particular place alone, we vaccinated over 1,000 people. And that was it really helped us to increase our coverage in terms of the yellow fever vaccination campaign. And what I realized is that what was very something that I didn't expect was I really didn't expect that a group who usually accepts health services all of a sudden decide that they would not receive their services. And that was why I shared my previous experiences with them, and then we were asked to go there and then do what we can possibly do to ensure that they get vaccinated. And then looking at it, this one, mostly community entry is one of the processes that Ghana Health Service usually recommend that before you provide any service, you have to do proper community entry from the health promotion books and then provision of service delivery. That's one of the strategies they usually provide. They ask us to follow. But because these are informal group of people, you really cannot meet them officially. So there's a way that we also have to meet them, to discuss with them unofficially to make sure that they patronize our services. And this one, there are other risks that one can also get, because the fact is that if you go there and then you don't officially introduce yourself, people may end up attacking you because they think that maybe you may be a threat to their operations. So it's important that when you are communicating, you have to introduce yourself very well and let them know your main mission of coming there, and then how to ensure that they are safe. When they know that they are safe themselves, or the service you are providing is going to help benefit them, they will buy into your decisions or whatever plans that you have for them. I think in summary, that's what I would say about my story and what happened during this November. Thank you.
Thank you, Samuel Badiekang. I'm going to go to Charlotte first. For any questions to clarify that you'd like Samuel to clarify before we go to Lisa Menning from WHO and to François Gas?
No, Reda, nothing from my end.
All right, let's then go to Lisa Menning. This was a story from Ghana told by Samuel. What are your thoughts and reflections, Lisa? What would you like to share with Samuel and with the group?
Thanks so much, Samuel. This is a really fascinating one about access and authority and power. And, I would like to think a bit more about really what I could offer there, because, your story is so unique to the situation there. And I think you navigated it really well. And you've really shown a lot of respect and understanding for all the different dynamics at play there. So I don't really have anything added to offer other than to just recognize all the subtleties and different dimensions of the problem that you're really aware of, and you're navigating very well there. So well done, and thanks for sharing that.
Thank you, Lisa. François?
Thank you.
Thank you, Reda, and thank you, Samuel, for presenting your experience and successful experience. I retain that among your solution that you have highlighted the power of the informal group in a community. And I think sometime, and you properly said, we're not supposed to meet them officially, but you have a way to meet them, and they were very important influencers to change the behavior towards and the acceptance. I was wondering, when you have done many campaigns, is this something you can anticipate? And where as a group, I think this one that never had a problem before, if I heard you well, but it was breaking. Do you, in your area, do you have with every campaign, a certain number of groups that react the same? or is it an accident that you have to react and properly solve? Can you anticipate and can you match those people who periodically raise issues for lack of information or other reasons?
Okay. Yes, what I would say is that it's usually this group of people periodically, because they are informal group of people that usually undertake certain operations. Mostly the legal authorities don't allow their operations, but periodically they do operate, and when they are operating, they are allowed to operate. So mostly when we are doing our health services, we usually look whenever they are in operation, we try to provide a service to them. And we know very well that once they are there are also people that are from the community that go there. So if you are to provide a service and then you cut them off, if there's any susceptibility to any diseases, they will contract it and bring it back to the community, because mostly their settlement is informal. There are no proper structured houses. Mosquitoes are exposed to a lot of mosquitoes. So mostly we actually, this is the first time we didn't really know about their mode of, in terms of the dressing code, the acceptable dressing code. So this is the first time that we realize that this is a new thing in terms of when you wear a certain attire, in terms of maybe red, it means danger. We didn't really know about that one. So this one is the first time that we discovered that. Thank you.
Thank you very much. Thank you, Samuel. A very nice story.
Thank you, François. We've got less than 10 minutes left in this assembly. For those of you who are joining us for the first time, I want to make sure you get a warm welcome. And members of the COVID-19 Peer Hub are vaccination, immunization professionals who've been working together since at least July 2020 and longer, for those who helped found this network. Very pleased to say that we have more events like this coming up that we will be live streaming on all the major platforms. So on LinkedIn, YouTube, Twitter, and Facebook. You can find us. Just look for the Geneva Learning Foundation or for the COVID-19 Peer Hub, and you should be able to locate our page and find when are the next events. Charlotte, do we have time for one final presentation today?
So I had Felicia Oluwafemi from Nigeria lined up. So I've just asked her to unmute. Felicia, if you're able to, in 5 minutes, could we hear your story?
Felicia, are you able to hear us and unmute? I'm asking her to unmute as well.
Yeah, so she's still muted.
Hello?
Yeah, hi.
Yeah, I'm muted. Good evening.
Evening, Felicia from Nigeria.
Yeah, good evening, colleagues, and good evening, Charlotte. This is Felicia from Nigeria. Am I supposed to share my screen? Can I share my screen?
Since we don't have enough time, Reda, what do you think?
Okay, let me just...
A short summary. Give us a taste of what's in your written case study. That would be great.
Okay, good. A short summary. I'm dealing with talking about a set. The title is Dialogue as a Strategy to Deal with Vaccine Hesitancy. And I am referring to a sect who is itinerant in nature, and they live in makeshift houses, and they're well organized and time conscious. So, and we refer to them in this country as the Fulani sect. You'll definitely find them in all states, almost all the states in Nigeria, because of the nature of their occupation. They are cattle rearers. So the issue was before the COVID pandemic. There was this issue of vaccine hesitancy, and we even thought it was just confined to a locality. Later, we found out that all of them spread around the FCT communities were really hesitant. They were not really getting immunized. So what do? With the government, we had to come up with a technical working group, in which a meeting was organized with the lead of a paramount traditional leader who, plus or minus before, has been engaging them in several activities. But when this issue of hesitancy came up, we paid advocacy visit to the paramount traditional leader, who brought them together in sects because they are in faction and they're well organized. So attendees came from the different sects all around the communities, their settlements. And they came in, there was a meeting, a dialogue meeting. The government knew about it. It was really broadcast. And we had even the FCT had the evidence of it. And this issue was actually resolved. And what was our role on this? Then I was a consultant and on the UNICEF, and we constituted this working group, and we looked into the issue, and a dialogue, a rapport, discussion was held, and the idea was now that everyone we regroup in the different sects, form a subgroup. This subgroup, we have to go into those communities and then talk to the mothers there. And by gender differences, there is that we dealt with only the males. It's the sex that we now go to those communities and instruct the women to bring out the children for vaccination. And doing that means the cultural belief of that set has to be respected, which we did. And we gave them the key messages. Vaccine are free, because we had time to build their trust. And aside, what we saw was that at takeoff, we have to respect their beliefs, the cultural norms, and which we did. And since then, there had been a quarterly meeting in the different sects. This was being manned by the health promotion officers in charge of the different districts, you will call it. And since then, the issue was resolved. Thank you so much, and over.
Thank you, Felicia. I have a question to ask you.
Go ahead, please.
What were the core reasons that they gave for their hesitancy for not wanting immunization?
Number one, they could not actually establish trust. They were thinking, they had this belief that, others might want to introduce something else into the vaccine, which is not safe. That was why our first key message was vaccination. The vaccines are free, and it's not going to really affect them. Then they thought it will actually make us reduce the population, which we tried to debunk. And aside that, there was a key thing we also used there. One of the health workers was from their clan. And they also told us they don't need a population to come and vaccinate them. They gave us the number. They want just the maximum of 4 people to come to their community, which we adhered to. And we had a good ride. So that was actually their fare.
Yes, thank you very much, Felicia. Thank you very much.
You're welcome.
I'm so sorry we are out of time, but if this leaves you thirsting for more, well, I hope you'll be joining François Gass and Charlotte Mbou for their sessions. And then on Friday, we have a special session with Lisa Menning from the World Health Organization. She is the technical focal point responsible for this area, this spectrum of vaccination demand, behavioral sciences, and she'll be with us on Friday to listen to your case studies, give you advice, share her thoughts, reflections, and guidance. So make sure you don't miss that. And I would like to ask Felicia to make sure that you come on Friday so that Lisa can share back with you her thoughts on what you briefly and very concisely presented today. Thank you so much. I'd like to offer and ask you, even if you're sitting alone in front of your computer screen, to put your hands together and to give a round of applause to the presenters and to all of the health professionals who've been fighting vaccine hesitancy on the ground. And you're really looking to the next stage of this exercise. Remember, if you are a member of the Peer Hub, your duty is by Friday to actually have submitted your draft case study. Next week will be dedicated to peer review. Thank you so much, and see you next week. Here are some of the messages Wonderful. Many, many more messages coming in. Let's have. So for Isabel, yes, so these case studies will be written and will be analyzed and shared with partners, members of the Peer Hub. Of course, will have access to them. Thank you for that question, Isabel. I'm just going to rewind, and I'm going to just share on screen all of the comments we've received. And yes, Tanushree, we especially appreciate folks from the subcontinent who are joining these sessions. It's late at night for you and other colleagues.